Hello friends, this is a case of laparoscopic myomectomy for large intramural myoma. This is an unmarried girl, so we are keeping it in the supine position. No uterine manipulator was used, Veress needle is used and preset pressure is 15. So we have insufflated the abdomen and after that incision will be enlarged to introduce the optical port. Optical port we are using here 5 cm above the umbilicus, because in the large myoma if you have a supraumbilical port you will feel confident to perform surgery, because if it is in the umbilicus, tip of the telescope will touch the uterus. So supraumbilical port is more convenient. And here optical port has been introduced. After that you can introduce the telescope and then you can follow the baseball diamond concept. The base of the myoma should be index finger, this is 18 cm, and then 7.5 cm lateral to the umbilicus, and the telescope is 24 cm away from the target. You will put second port, that will be your right hand. Here we will perform the surgery by only 3 ports, and this second port will be 5 mm port, and the third port will be 7.5 cm below the second port. Third port will be initially 5 mm and later this port you will convert to 15 mm for the morcellator, and this will be the position for the third port. So first you should put the Steve Tendenberg position, and all the bowels should be pushed away from the sacral promontory, it should be pushed up, and then third port will be introduced. We can see this is a large intramural myoma. Unfortunately this patient has received some GnRH, so myoma is soft. Soft myoma is sometimes little more difficult to remove, but we will remove it. And first we will use the vasopressin, that is 1 ampoule of the vasopressin is diluted with 100 ml saline, and then you can inject the vasopressin with the help of aspiration needle, and you will keep on injecting slowly all the complete 100 ml diluted vasopressin, and it will turn marble white appearance. You can see transient ischemia is already started and the color of the uterus is becoming pale due to ischemia. So after injecting the vasopressin, we will remove the aspiration needle and then we will start the incision from the same side from where we have injected the vasopressin. We are using here the harmonic scalpel in the right hand, and left hand has atraumatic grasper to just hold the seromuscular layer of the myoma, and slowly incision is enlarged so that we can get the proper plane of the myoma, and then we can use the myoma screw to hold the myoma to enucleate it. So here harmonic is better than any other instrument, because harmonic is basically a scalpel, so it cuts better, and together with you will get hemostasis also. Another advantage is once the harmonic vibrates at 55,500 vibration, then it makes a spontaneous breaking of the hydrogen bond, and it make a better plane of the tissue rather than the hook or the seizures, and this incision should be optimum so that you can remove the myoma. Care should be taken that there should not be overshooting, because you are near the iliac vessel, so overshooting should not be there. After cutting serous layer, this is the muscle layer, which is cut. And then you can use the myoma screw in the left hand. Now at this point also little muscle layer will be cut, so that you will get the capsule of the myoma apparent. And now we can see this is the myoma, which is quite soft. After that, in the left hand, this is the myoma screw, and you can put on the base of the incision site, and slowly you can separate it with the help of, you can use here, there is a myoma rod also, that also can be used. If we are using harmonic scalpel, it should be used carefully, because excessive force over the harmonic can bend the harmonic and it can spoil your instrument. So you should keep on rolling the myoma, and repeatedly myoma screw should be applied over the base, so that traction can be optimized. The fluid which is coming, you can see this is the injected remaining vasopressin that is coming out, and with the diluted vasopressin it also creates some hydrodissection, that also helps you to achieve a plane. So this is pushing and pulling technique. With the myoma screw you should pull it cranially, and with the harmonic you can push the layers of the muscles, and keep on relocating the myoma screw to optimize the traction. And we can see approximately 2/3 of the myoma is out, and then again myoma screw is relocated to the base. So this myoma is almost out. There is, this is out. There is one more myoma there, that also we will remove. But here we will introduce the needle and the suture. We will keep it there. So we can see there is a white color. There is a small portion of another myoma that is also visible. So better to remove that also, because later that can also grow. So we will keep the needle for safety, just pierce the needle and leave it there so that it will not disappear somewhere. This is in this muscle. This is muscle layer. We will not take it into the this is the myoma. So we'll just kept at this point and we will remove it, because it is important to remove that one also. So this extent of myoma was found. It is too soft. It looks like so soft because once the patient takes GnRH, this condition develops. So we are using again the myoma screw. And this will also be removed. Again myoma screw is applied on the base. And slowly with the harmonic you can secure the feeding vessels. care should be taken that cavity should not open. This is scissors, and scissors is used to separate this myoma. And now we will use the baseball suture here to close the myoma. So already one starting bite is taken to the serosa, and in the first layer you can just take the muscles. So here the muscle to muscle bite is taken so that it will achieve the hemostasis also, and this is continuous suture. You can stretch the tail end so that it will further tighten. This is muscle. Again one muscle layer further. After reaching to the other end, you can take the needle out of the serosa. So here needle is taken out to the healthy tissue over the serosa, and then in returning you will take baseball suture. So in the baseball always you should come in to out. Here this is in to out, and that you will do both the sides. This side also in to out, and here also you will go in to out, so that margin will be inverted. And other side again in to out. And you should keep on tightening it by just pushing the tissue, and again other side in to out. That will not leave a raw area outside, and there is less chances of adhesion. But you have to take a reverse bite with the needle, so that is important. and tight it every time by pushing it by the open jaw of needle holder. Again reverse bite. Tight it, and then you will come out again out of the serosa. Tail is there already, first layer tail is already projected, and then you can terminate it. Pull the tail and terminate it. Needle end of the thread is little short, still you can terminate it. Surgeon's knot or 3 times square knot can be given. And in this baseball suture you cannot see any raw area outside, and there is no bleeding also. So it is, suturing is complete, knotting is over. Now you can suck all the blood which is collected, and you can check the hemostasis. There is no bleeding, and the blood in the cul-de-sac is sucked out. And you can wait, if there is any bleeding you can take couple of more bites, but there is no bleeding. And minimum blood loss is there, maximum blood loss is 20-30 ml. And then you can cut the suture. And bring the needle out with the 5 mm port. After that 15 mm morcellator will be introduced, and now morcellation will start. This is the tail end, you can take it out. You can do the morcellation in more safe endo bag, but this patient is quite a young patient, only 21-year-old. So there was no risk of any malignancy, so we are not using more safe endo bag, and the tissue is morcellated with the Storz morcellator. Morcellation is a time-taking procedure, and you should take care, as we have discussed before, that morcellator should not go near the tissue to morcellate. Tissue should come near the morcellator to get morcellated, and slowly morcellation will continue. Morcellation will take little time depending upon the size of the tissue. Minimum 15 minutes, sometime half an hour to 1 hour time is also taken in large myoma. So during morcellation you will have one more advantage, that the time which you are spending in morcellation, you can check your suturing. If there is any bleeding, that also will check. That's why before starting the morcellation, just remove all the collected blood from the pouch of Douglas, and if it is there in anywhere like Morrison's pouch or Palacolic gutter, because if at the end of the morcellation you feel that those spaces are again filled with the blood, that means you have to put a drain, or you may have to take couple of more extracorporeal square knot or western knot to give tension suture to stop bleeding. So during morcellation, you should also keep on watching the uterus which you have sutured, that there should not be any bleeding. There are different type of morcellator in the market. Gynaecare morcellator was very good from Johnson & Johnson, but it is no more available because Ethicon has recalled that morcellator due to FDA issue. But starch morcellator is there, and some other Indian morcellators are also in the market. So it needs either 12 mm or 15 mm port. 15 mm is better because it will do the faster morcellation. And it is very important that morcellator ports must be closed, because there is a high incidence of hernia if you will not close the port which is used for morcellator. So carefully you should morcellate and take care that any portion of omentum or sigmoid should not be caught during morcellation. So you should keep the only minimum length of the morcellator inside the abdomen, and always pull the tissue in the morcellator rather than pushing the morcellator over the tissue. Here you should use tenaculum. Grasper is not good, because grasper, once you will bite the tissue, the jaw of the grasper may remain open and it can damage your morcellator. Tenaculum, because it has only one tooth on either jaw, so it bites the tooth better, and then it will not hit the sharp edge of the morcellator. Time to time you have to push the morcellator away from the tissue, and tissue should be brought little away to hold it, and a good bite should be taken with the tenaculum. Otherwise, in the halfway your tissue may slip out of the tenaculum and it will take more time. If you will take a good bite, then bigger length can be used, and there should be a very consistent pulling, because if you will pull it more to do faster, it will break, your tissue will break and you have to catch it again. So there should be very firm grip and slow pulling effect. You should not try to pull it fast, otherwise it will keep on breaking and you will bring a small pieces. At the end of the morcellation also you should be careful that any fragmented tissue must be collected out separately with the grasper, and you should not leave those fragmented tissue inside the abdomen. So we can see approximately 2/3 of the morcellation is complete, and only little tissue is now left for the morcellation. Morcellation need patience, and it need very good attention so that it should not get any other bowel loop nearby. The telescope should always watch, and the light cable of the telescope should be at 2 o'clock position. We can see one arrow on this circular camera. This arrow means telescope is looking towards the arrow, 30-degree telescope. We can see there is a arrow on this black circle of the camera, and this arrow means this arrow is at 7 o'clock position. That means 7 or 8 o'clock position. That means light cable is kept at 2 o'clock position. So this arrow gives you the direction of the 30-degree telescope. So always the telescope should be held in such a way that your morcellation should be under vision. Even for a single second, telescope should not leave the unattended. Now this is the last part, and slowly the tissue will come out. Time to time you may have to catch it and again pulling it out. And this is over. Now this fragmented tissue also should be taken out carefully, and then you have the one more port, so you can bring a grasper and a small pieces you can collect carefully, and you can bring those tissue also out. After that, if it is required, little suction should be done. Here in this case we have used the interseed because this is unmarried girl and she need the pregnancy letter, so better to on the suture line you can drop a interseed. Here large interseed, although 15 by 15 interseed is sufficient, but here we are using 20 by 10 interseed, and you can spread the interseed on this area and just press it so that it will take care. And after spreading the interseed over the suture line, although absolutely no bleeding, but just for prevention of the adhesion, you can spread it, and then slowly you can take the gas out. Once the abdominal wall will deflate, automatically this interseed will come into the contact and it will take the fluid from surrounding. So thank you very much for watching this video. Have a nice day.